So this kind of brings us to our very last category of the categories of AKI, urinary obstruction. So this really is going to be caused by obstruction of the outflow of urine anywhere from the renal pelvis to the urethra. And the renal failure that we see caused by this can either be acute or it can be subacute if it occurs over time. When we think about the different causes of obstructive uropathy, they include calculi or stones. Particularly if I have a stone or a patient has a stone at the ureteropelvic junction in a solitary kidney, obstructing outflow of urine, that's going to result in AKI. Or think about a patient who might have bilateral stones. And not only do they have little stones, they have these big staghorn calculi that take up the entire renal pelvis. That can really obstruct the outflow of urine. So that can result in an AKI. And when we have stone disease, we can see it in our younger patients as well as older patients. We can also have anatomic abnormalities, most commonly seen in children. So children who have problems with the positioning of the urethral valves, people who are born with congenital strictures, or adults who develop that over time because of a traumatic injury. And then people who have stenosis at the ureterovesicle or ureteropelvic junction. Again, that just means that there's an area of narrowing where the ureter anastomosis with the bladder or the ureter is connected to the renal pelvis. Now, the most common, and what we saw in our case, is benign prostatic hyperplasia or BPH. This is most common in men over the age of 50. Another is urethral stricture, as we talked about. And then finally, malignancy. So malignancy, which will include malignancies of the prostate, the bladder, or any kind of extrarenal pelvic neoplasms that end up compressing the outflow of urine, essentially, from those ureters. Okay, so if our patient presents with obstructive uropathy, what can we do in order to make that diagnosis? Again, we're going to be diligent detectives. We're going to do a very thorough history and chart review. If our patient has BPH, we're really going to ask them about lower urinary tract symptoms. That means, do they have hesitancy when they're voiding? Do they have dribbling? Do they have double voiding, feeling like they've voided but then have to void again? That means that they have incomplete emptying, and that's a very big sign or symptom that this patient has BPH. In a patient who might be presenting with stones, they could present with flank pain, depending on where that stone is located, or they can have gross hematuria, again, as that stone kind of traverses that ureter, or in the bladder even, you can develop hematuria. And then, of course, for people who have malignancies that are compressing the ureters, then it's going to be important to look for that history of malignancy. Physical exam can be helpful as well in terms of diagnosing our patients. For BPH, it would be important to do a digital rectal exam to palpate for an enlarged prostate. In patients who have stones, we might want to do percussion at our costovertebral angle to see if our patient has tenderness. And then in the case of malignancy, it's always important to do a thorough abdominal exam and really palpate for any abdominal mass in the pelvic and abdominal region. Imaging is probably one of the most important parts in diagnosing post-renal or obstructive uropathy. And our imaging modality of choice is going to be renal ultrasound. Here we can look for things like hydronephrosis. As seen in the image over here, you can see on ultrasound we have a kidney with a very dilated renal pelvis and a very big boggy renal cortex. That's from essentially reflux of urine back into that kidney, enlarging it. If our patient is presenting with a stone, it'd be important to get a CT of the abdomen and pelvis without radiocontrast, which will highlight the stone. So very easy to see calculi. And we can also see pelvic masses if we want to use contrast, although we'd want to avoid that in our patients who have AKI. On laboratory evaluation, that high BUN to creatinine ratio is going to be more reflective of post-renal. Again, if you think about what's happening, you have obstruction of urine outflow. So you have stasis of urine within that tubule, so plenty of opportunity to absorb urea during that time period. And again, if I'm looking at that urinary sediment, it's oftentimes bland. There's no cellular elements, there's no casts. In the case of nephrolithiasis or stones, I may be lucky enough to see some crystals, but they're not always present. So how do we treat our patients once they present with obstructive uropathy? So for BPH, we can actually do a urinary catheter inserted into the bladder for decompression. We can also remove medications that precipitated the obstruction to begin with. Remember our patient, he took a cold medication, which was an alpha agonist. So that increases tone at that bladder neck. So we absolutely want to ensure our patients are off medications that can do things like that. And there's also medical and surgical therapy for prostate, right? So we're going to give our patients alpha blockers, and we can have our urology colleagues get involved, and they can definitively cure our patients with BPH. For stones, we can remove the stone, and that's when I typically get my urology colleagues involved, where they can do a percutaneous nephrolithotomy, or they can do shockwave lithotripsy. We'll be talking a little bit more about that in our nephrolithiasis chapter. We can also have our urology colleagues place a ureteral stent from that renal pelvis all the way to the bladder, which helps to keep that ureter open and allows free passage of stones into the urine. And finally, we can get our interventional radiology colleagues involved to place a percutaneous nephrostomy, as shown in this image over here. So essentially, our IR colleagues will place the catheter directly into the renal pelvis, which completely obviates the obstruction and allows free passage of urine.